truly a pleasure to introduce a colleague who's been with us now for almost 3 years, I would say, Dr. Veena Manja, who is a cardiologist by training and does her clinical work at the VA, but has been associated with us as a visiting professor and recently completed her PhD in Health Research Methods, Evidence and Impact from McMaster in Ontario, and has participated with our outcomes group that was originally led by Dr. Cook for quite some time. And we are excited to hear today how we can improve our analysis of clinical decision making with data-driven analysis. So, Dr. Manja.
Hello all. Thank you for the opportunity, and thank you, Dr. Farmer. When we moved here, you gave me a place to call home. We moved from Buffalo about 3 years ago. Just two things about the previous case. The EF is very dependent on preload and afterload. And if this patient was in pressors, it's not surprising. It was 15% at baseline, and it was 30% later. And atrial fibrillation, I think the risk of thromboembolism and atrial fibrillation is variable, but it's a 10-year risk of anywhere between 2 to 3 in people with very low risk to up to 10%. So it's not a very high risk in that short time frame when they are in the hospital. So anticoagulation with IV heparin for atrial fibrillation, in my opinion, you have to consider the risks benefits. It's likely you do not need to in the acute hospital setting. In the past, we used to worry a lot about protein C proteinase deficiencies and other things, but that's no longer the case. So just for future reference. So we used to live in Buffalo, and I've been a cardiologist at the VA there for many years. I went back to school to get my PhD from McMaster, which is right across the border from Buffalo. It's in Canada. And that's considered by some as the birthplace of evidence-based medicine. Dave Sackett is the person who, along with...
I'm going to interrupt a minute just to ask you to stand a little closer to the microphone.
Okay.
Just because we're recording and it doesn't...
Okay, sure, thanks, yes. Was the one who pioneered evidence-based medicine and making sure that our decisions are based on the evidence that we have as much as possible. So the learning objectives for this are to understand grade. That's a framework to assess the level of evidence, the certainty in the evidence in the body of literature. To critically appraise a systematic review or a result of a literature review for certainty in the evidence and apply the grade framework to a body of evidence. This was part of my PhD dissertation. It was a mixed method study looking at clinical decision making in cardiologists. In cardiology, we do a lot of procedures, and many of those procedures are not necessarily warranted. Even though most cardiologists know what the guidelines say, there is a lot of guideline discordant decision making. And there are various reasons for that. So this particular study, we had a survey which had 4 clinical vignettes, and then it had several different questions, and why did you answer this way, and so on and so forth. And based on the results, we had an interview qualitative study that followed, asking the cardiologist why they made the decisions they did. And it turns out that there are many factors, right? Evidence is not the only factor that goes into decision making, although arguably it should be a very big factor in that. So there was one case looking at a patient that comes to the ER with non-cardiac chest pain, clearly non-cardiac, and asking for disposition. A significant portion of cardiologists said that they would admit the patient or do more tests where it was clearly not indicated. And based on their responses on the survey, we could see that there were differences in how they rated different parts of, different reasons as to why they chose one versus the other. It was, we could go back to the survey and see that there was a distinction in how people thought before when they made decisions. And one of those is the evidence-based, the knowledge, the depiction, a fair depiction of risks and benefits, and also shared decision-making with patients. So for the assessment of risks and benefits, then it's important to somehow get all that there is in the literature and decide what a particular treatment, a diagnostic test, what the pros and cons are. So in other words, how confident are we in the results of a study? Just because a randomized control trial says that this is the effect estimate for benefit and these are the harms, it doesn't mean that that's necessarily the truth, or in the results of a systematic review or meta-analysis. How confident are we that that is near where the truth is based on the sample that we have in the study? And will further research change the results? So just to clarify what I mean by certainty in the evidence versus the evidence itself. So the 40% chance of showers, that's the effect estimate. When we have a meta-analysis, we combine what's out there in the literature and come up with a number saying the relative risk is 1.5, that's the effect estimate. But then how certain are we that that relative risk truly represents what is likely to happen? So that's our certainty in the effect estimate. And just a recent example with all the literature coming out on COVID, there have been several reviews now, several reviews of studies and several reviews of systematic reviews, suggesting that the quality of those studies is very poor. And so just because it's difficult to do these studies doesn't mean that flawed methods and data will somehow result in credible results. So I think we must take a moment to decide whether the results that we have, if we can be certain that they are what they say they are. So GRADE is a framework, as I said, to assess the certainty in the evidence in the body of evidence. It started in 2000. Dave Sackett was the founding chair of the Department of Clinical Epidemiology and Biostatistics at McMaster. He started the evidence-based medicine movement. And this is Gordon Guyatt and Holger Scholman. They are the two who started GRADE back in 2000. So it's a transparent framework for grading the certainty in the evidence. Not everybody has to agree, but everybody has to say why they thought, whoever grades the evidence, why they thought it was high, moderate, or low quality. And there are levels in the certainty evidence, and then many big societies, bodies have adopted GRADE to assist with guideline development. The WHO was one of the first organizations that adopted GRADE. I'm currently working on hypertension guidelines for the WHO. BMJ, I have worked on a couple of projects for the BMJ. They have something called Rapid Recs, where they come out with guidelines that are user-friendly and facilitate shared decision-making. Cochrane, NHS. I looked for surgery societies, and the Vascular Surgery Society and the Eastern Association for Surgery of Trauma use GRADE. So, as I said, it's about assessing the confidence that the point estimate is in fact correct. Just because we have a point estimate doesn't mean that that is true. And so with GRADE, we assess all factors that determine how confident we can be in the results, and then they are rated as high, moderate, low, or very low certainty. And you have to provide reasons for those judgments. And the body of evidence is assessed for each outcome separately. So for mortality, the certainty in the evidence may be different than for myocardial infarction, than for stroke, than for quality of life, because different things go into those decisions. So if blinding, for example, is not optimal in, say, people who assess outcomes. The mortality really, you don't have to be blinded to say yes or no. So then the certainty in that for that particular outcome will be higher. So then what do we look at when we decide whether or not we can be confident in the estimate of effect? Is it the trials? Is it how reputable people conducting those trials are? Is it based on how big, how large these trials are, the included sample? Is it based on the total number of events? Does it depend on other statistical results? So that's what the grade domains address. So in grade, randomized control trials start as high quality evidence, and that can be downgraded all the way to very low quality if the trials have problems with them. And observational studies start as low quality, but they can sometimes be upgraded to high quality evidence. And it's based on 5 domains. The first one is the risk of bias. I'm sure all of you know about risk of bias. You studied about it in medical school. And we use the Cochrane risk of bias tool, which I'll briefly talk about. And there is inconsistency, or how consistent are the results across studies, because that can be one indication to say that if it's very consistent, that must be the truth. Indirectness is there evidence to support whatever decision you are making? Maybe we don't have data on people who use meth, and we have this patient that uses meth, so we are extrapolating from a slightly different population. So depending on the degree of indirectness, we may downgrade. Then imprecision is how precise is your result, how wide or narrow are the confidence intervals, and then publication bias is many times negative studies, especially if it's a small study, they may not get published. And there are several things that can upgrade the certainty, especially in observational trials. So as I said, the grade approach, the certainty varies from high to very low. RCTs, high quality, observational studies, low quality, and then it changes depending on different factors. And the downgrading, as of now, you can downgrade by 2 levels for each domain. If there is no serious issues, then you would not downgrade. If it's serious, downgrade by 1 level, very serious, downgrade by 2. And I have some examples, and I'm happy to answer any question. And it's a lot of new information, different information. But what do these ratings mean? So based on several papers, meetings, conferences, this is what the rating of high means, that we are very confident that the true effect lies close to the effect estimate of that meta-analysis. If it's very low, it means that we have very little confidence in the effect estimate, and the truth is likely substantially different because the data that we have just is not good enough. So risk of bias, it's based on several decisions that are made in the randomized controlled trials, sequence generation, allocation concealment, blinding. So I'm happy to elaborate more for any of these, but it's different steps in the RCTs that decide whether you truly balance the prognosis in the 2 groups. That's the whole benefit of doing an RCT, is you don't have any unknown confounders necessarily more in one group than the other, for randomization. And with the Cochrane risk of bias tool, if you it's assessed for each study. So for example, in meta-analysis, if you have 9 studies, those are all the authors of the studies, you would assess each study for the risk of bias in different domains. And then green is low risk of bias, red is high risk of bias, yellow is it's unclear, there is not enough data in the paper. And then based on that, this would not be downgraded, because overall these were very well done randomized controlled trials. The only place really where most trials got a red was for blinding of data analysts, and then you have to decide how likely is that population, that group not being blinded, will it result in a biased value? Yeah. So inconsistency depends on the point estimates of different trials that you're included in your meta-analysis. If they vary widely, if the confidence intervals don't overlap, if the statistical test for heterogeneity or the I-square suggests that there is substantial heterogeneity, then you would downgrade. Most of the time it's downgraded by 1. Infrequently, you do downgrade by 2. And if there is inconsistency, then you have to go back and look at the different trials and decide why there is inconsistency. It could be that it's a totally different subgroups or different PICO in the different trials. It could be populations for different, interventions for different, and so on. And then you would downgrade, as I said. And just because there is inconsistency, you may or may not downgrade. It's again a judgment call. There is minimal heterogeneity here. We would not, but it's something like this. But all data shows effect in the same direction. Whether or not you downgrade just because the effect estimates are different is again a judgment call, and you would note that in the evidence in the summary of findings table. Indirectness, again, as I said, it's how well does the available evidence answer the question. If you have studies that answer that specific question very well, you would not downgrade. A lot of times it's because of surrogate outcomes. We have many surrogate outcomes in cardiology. Just because we control blood pressure doesn't mean the stroke risk necessarily goes down. Just because the HbA1c is lower doesn't mean that many of the complications of diabetes go down, and that the risks and benefits combined of treating so the overall outcomes are any better. So then you may downgrade if you only have data for surrogate outcomes. And indirect comparisons, although these days most of those we do a network meta-analysis. In precision, as I said, it depends on how wide the confidence intervals are. This is based from a systematic review looking at TAVI and SAVR. This was for a BMJ rapid rec that I'll talk about briefly in the end. And this was for a pacemaker, needing a pacemaker. We downgraded by 1 because there was so much variation. The effect was imprecise. Publication bias. It's been well reported, I'm sure all of you know, that small studies which are negative may be difficult to get published. And so they may be systematic under or over estimate of the effect due to the publication bias. It's probably higher for reviews based on small trials, and studies funded by industry are more likely to have outcomes that favor the sponsor. And it's usually studied using a funnel plot. So this plot is based on, this is the effect estimate, say the odds ratio in this case, and that's the standard error. So that's just, if it's a large study, the standard error will be lower, so it's reverse, right? So this is a higher standard error and goes low as it goes up. So if all the studies done on a particular topic have been published, it should look like a funnel. If the studies that were small, that were unfavorable, so if they're small studies, the standard error is high, and the odds ratio, depending on what your outcome is, it may be high or low. If it's not shaped like a funnel, there's likely publication bias, and then you could downgrade because you're not certain if you have all the evidence there is to make a decision. This is one example from cardiology. This is using intravenous magnesium in patients with acute myocardial infarction. There were lots of small trials early on that favored it, but then there was one large trial, the ISIS-4, that was published and which showed no effect. So that's just, it does happen. And for observational studies, it's the opposite. You start with low, and then you can go up to high or moderate. And things that upgrade the quality of the evidence, one would be if there is something like parachute preventing death. You really don't need a randomized controlled trials. It's just so convincing, the data, the observational data, that you would upgrade that and say this is high quality evidence. The other one is for mechanical heart valves. You need anticoagulation. You do not. We don't really have many randomized controlled trials for that, but based on observational data, there is substantial benefit. So you would upgrade the evidence. Another domain that you look at for observational data is if there is a dose-response relationship, and this is an example for radiation and malignancy, and you can upgrade that. And in the end, this is what a summary of findings table looks like. So this total mortality, depending on all the data that we have so far. So it's usually a meta-analysis, then looking at the outcomes, whatever is important to the people that are making decisions. Then standardized controlled trials or observational studies, and based on the risk of bias, inconsistency, and so on, you would downgrade or not. And if you downgrade two different domains once, then it goes too low because you take away one box for each. If you downgrade only once, then it's moderate certainty evidence. And this is the relative risk based on the risk ratio, based on the meta-analysis, and then there are various decisions based on how wide the confidence intervals are, what the absolute risk is, and so on, that are taken to downgrade. So this is from trauma, surgery, and acute care, where they had used grade. Cochrane uses grade, and they looked for Cochrane guidelines that pertain to surgery. This was one comprehensive geriatric assessment for older people admitted to surgical service, and I know we had talked about it briefly with Dr. Kokenar, Ellie, so this is that came out relatively recently, and so for mortality, doing a comprehensive geriatric assessment for older patients admitted to a surgical service, there is moderate certainty evidence that there is a benefit. For discharge to an increased level of care, there is high certainty evidence that these people, if it's a comprehensive geriatric assessment is done, then the probability of this being discharged to a higher level of care is significantly low. And for length of stay. So this is then there's a footnote that says why they downgraded. And that's the risk of bias in all the studies that were included. The Forest plot for mortality, they downgraded for imprecision. Here for inconsistency, that's the length of stay. As you can see, the effect estimates are all over the place. And another example where they were very explicit about all the decisions is the perioperative beta blockers for preventing surgery-related mortality, morbidity in adults undergoing non-cardiac surgery. Then most of it is low quality or very low quality evidence, but then there's a footnote explaining why they downgraded. And so this is an extension of grade, and this is the BMJ RapidRec document that I was talking about. So based on all the evidence, the patients, if you want to support patients with shared decision making, then we need to have the evidence for benefits, evidence for harms in a way that the patient can understand and participate in their own decision making. So this is from BMJ RapidRec for SAVR versus TAVI, and based on age, there was different, the effect estimates were different. So age greater than 85 strongly favors TAVI in the younger, and this is from 2016, and data has evolved, and they're working on the next iteration, but at the time, age less than 65, there was a strong reason to favor SAVR. And then if you click on any of these, if you click on for age greater than 85, it gives the numbers from a meta-analysis of all randomized controlled trials that have been done so far. So death, there were 45 fewer deaths for TAVR versus SAVR, and so on and so forth. And so, people differ in what their preferences are, and so different people may make different decisions if this data is available. It also says what's our certainty in the evidence for each of these outcomes, and what other certainties there are that may impact decision making. This was another one looking at peer foreclosure for cryptogenic stroke. And there were 3 different comparisons here: peer foreclosure with antiplatelets or anticoagulants, and antiplatelets, anticoagulants. And again, there is all of that is in the background for each rapid rec, where you just click and then it'll gives you the numbers for different outcomes that may be important to patients. That's all I have. I'm from Buffalo, and the Buffalo Bills did great. So that was after 25 years. They won a playoff. So.
So thank you, Veena. Surgeons have been accused historically of not being evidence-based. In many ways, it's not really true. Although I will say that we might have been slower than others to bring the rigor to a lot of the decision making. Although a lot of what we do reminded me of the parachute, right? Some of the procedures and the interventions we do, if you don't operate, the patient's going to die. You don't need a randomized controlled trial to figure that out. It's a parachute kind of problem. But however, I do think for all of us, really having a good understanding of how to grade the literature, how to understand just because it's published doesn't mean it's gospel, is really important. And that's one of the reasons that I have felt so strongly that regardless of what you're going to do in your profession, spending this time in, quote, the lab, analyzing the literature, really learning how to review all of these things that get printed is so important so that you make the right decisions for your patients. So thank you tremendously for that really rigorous review of how to think about this and where we can get resources. My first question is, before I turn it over to my colleagues, is the Cochrane really good? Is that the best place to go if you had a question, or the first place to go perhaps if you had a question about, is this, what is the evidence for whether this is the best treatment?
Yes, they use a rigorous systematic review methodology, and they will, their documents are very long. They're all available online, but they will tell you if they did not include certain trials in their meta-analysis, why they did not include. So you may disagree with what they say, and that's okay, but you know why they chose to make those decisions. And they have been one of the pioneers in developing methodology to assess all of this. So Cochrane, NICE is in the UK. They have many guidelines that are very rigorous as far as the systematic review. CADIT in Canada. So in the US, I think we're just not as centralized in the US, but many different organizations are using GRADE. And you don't have to use GRADE. You could use something else, but it's just a way of explicitly, transparently assessing the certainty, and GRADE is one that's caught on.
Dr. Cook.
Thank you. That was a wonderful presentation, and congratulations on the Buffalo Bills.
Thank you.
Yeah.
Yes.
This work, sort of GRADE, touches on really appropriateness of care, and you talk about cardiology, which historically kind of has a gray area in regards to appropriateness of care. In the surgical specialties, oftentimes we are held very accountable for appropriateness of care, specifically cardiac surgery, transplant surgery. There are specific, publicly reported, often adherences to appropriateness of care. This work, as you showed in those later graphics for TAVR, SAVR, and PFO, works really nicely in regards to patient-centered shared decision-making. So it works well on that regard. But what about sort of the regulatory aspect in order to push appropriateness of care? Does payment bodies such as CMS or some of the other private payers take a look at this approach at evidence-based medicine and make sort of regulatory decisions on payment for appropriateness of care?
So yes, but not in the U.S. CADIT in Canada, NICE in the UK, our bodies in Australia and New Zealand, and UNETA is a HTA agency in Europe. They all have health technology assessment. So, and that includes drug, that includes devices, that includes home care. So technology doesn't mean technology as we commonly use that term, but every thing before approval, for example, in Canada, I was in Canada for some time. So they go through a systematic review and meta-analysis, so a review of clinical effectiveness, and then they go through a review of cost effectiveness, and based on that data, they approve or not any new technology, and then that goes hand in hand with reimbursement. So the thing that they have been able to do is bargain down a lot of prices from drug and device companies, and there have been, I have been around when drug companies come back 3 times. So they keep going down on the price based on all the evidence and what the benefits and harms are and what cost effectiveness is. Yeah, so yes, it is a tool that, and this is great, is a small part of all of this. So that's one. The second part is it's extremely difficult to change behavior. And we have PCI similar to the STS database. We have database for PCIs and all procedures, but things like ordering an echo or getting it, you can make arguments both ways, right? We know that that may not necessarily be needed, but then there are so many different reasons why we get another echo. And I think it goes down in training too. One thing I feel passionate or strongly about is that we have all these guidelines, this evidence, but then when we train, they look at us, how we practice, my fellows, and then they do what I do, not necessarily what's in the guidelines. And I think there's a big lag between all this and change in practice.
Okay.
So.
Great, thank you.
Sure.
Dr. Rich.
Well, it was a wonderful presentation. I particularly like the last set of slides. The graphics certainly brought something new to me, and I was really pleased to see that. They just look really good, and they convey a lot of information, and they help explain the non-binary approach to so many medical diseases and why there's so much decision-making that it goes into medical care. It's not so black and white. And I think in some way it also helps explain why it takes so long to adopt any new intervention, and because so much of it falls within that sort of gray area of weak evidence or strong. That's way of background by saying I'm on the editorial board or an editor of a number of different surgical journals, and we just had a 2-hour meeting last night for one of the journals on how to change the editorial board in our practices. And one of the areas that came up was the idea of a full-time statistician reviewer of data quality and labeling each paper with some sort of measure of the quality of its data. Now, it didn't get a lot of traction in the board meeting, but I'm wondering what the status is of editorial boards that you know of about reviewing the data that's submitted to them and giving it a ranking as you're proposing in this talk today.
I don't know about editorial boards, but I know guideline organizations that make guidelines. Almost the ones I have been involved with, they have at least one methodologist, which is slightly separate from a statistician, because it's not all about the statistics and the numbers, although that has so much that needs to be considered as well, but also the methodology of the trials, of the systematic reviews.
Yeah. Anyway, interesting talk. Thanks.
That's why it's so hard to describe health services research now, because a methodologist is different from a statistician, it's different from a big data analyst. I mean, that's an umbrella that encompasses a lot. That's actually basic science encompasses a lot. So, Dr. Greenwald.
Yeah, I appreciate your talk also. Mine's more of the mechanism of using grade, because I had proposed a study in a grant and talked to the grade people, and I got the impression it's a subscription. You have to pay them to do this work for you. And so do you have to do this? Can you just do it on your own, or
Yes.
kind of how does the mechanism, because if
So,
I want to propose a study using the grade system, don't you have to subscribe?
So you have to, if you want to do a lot of things, like many outcomes and stuff. But gradepro.org, gradepro.org, that's their software, and it's free for up to 3 people to collaborate together. And I'm not sure exactly how many how much of the volume of data that you get free to analyze, but that's free as there's a starter that's free.
And when you say like BMJ's part of it, do they pay a subscription to it, or is that how it works? Because I know it's not just, oh, it's a good concept, we'll do it. It's more of you have to work with them. And we proposed a surviving sepsis campaign for burns and talked to them, and we're ready to go, but never got funded. So we're still considering doing it. But it was more of we had to pay them to help us do the quality evaluation and things like that. So that was more of my question.
Yeah, so these are all available on the BMJ. If you just type in on Google BMJ, it's rapid recs, it's rapid recommendations, and the goal was to have as short a turnaround time as possible between availability of new evidence and these recommendations, so that lag between evidence and implementation would be decreased. So it's BMJ rapid recs, and there are about, I think, 30 some rapid recs there already, but the only surgical ones are orthopedics, knee surgery versus physical therapy versus not. So I looked for surgery ones, and these two I was a part of, so I chose these, not many with surgery. And this is also, that's a different collaboration called MAGIC, which is an offshoot of GRADE that comes up with the rapid recs, and they have a collaboration with BMJ to come up with these. They have recently published COVID guidelines, treatments, and that's a living guideline where it will be constantly renewed based on new data. So systematic review will be updated at certain time periods too.
It's almost like grade adds basically bias to your study and saying that it's got better quality. So if you pay them, you get at least get evaluated in that way.
Thank you.
Well, thank you again, Dr. Manja. We really have appreciated all your contributions to the department and look forward. We're not letting you go away completely. So we really look forward to ongoing collaboration.
Thank you.
I want to say